My name's Tom Hogan, and I'm the Secretary for the National Alliance for Thrombosis and Thrombophilia, also known as NAT. I had just come off the submarine USS Providence in 1992, and I had my first DVT. While hospitalized, they also found out I had a pulmonary embolism, so I had a high resting heart rate. In 1995, I suffered a second DVT. This was also unexplained, as was the first time. I was eventually sent to Harvard Medical School, where they did some lab work on me and discovered a genetic clotting disorder, which is the cause of my blood clots. Around the 2002 timeframe, the Centers for Disease Control and Prevention was interested in finding out what impact blood clots was having across the nation, and they formed a steering committee, which I was an original member of, that did a year-long needs assessment, and that was from 2003 to 2004. In 2004, our group, which is a group of patients with some help from some medical doctors, presented our findings to the CDC, and the major impact was that there was no support groups out to represent the patient community and their families. As a result, the National Alliance for Thrombosis and Thrombophilia was created. December 2008, I finally had my right hip replaced. This was a result of 4 years of living with degenerative arthritis. The pain had gotten to the point where it was just miserable trying to do anything daily, doing stuff with the kids. Having survived 2 separate DVTs, a pulmonary embolism, and also having genetic clotting disorder, I knew I was a high-risk patient. Because of that fact, I was also an educated patient. I researched what precautions needed to be taken. Meeting with the doctor, he went over the risks, but none of them were really described as something that you need to worry about. You know, that 1 in 100 patients may observe this. But knowing that I had this problem, I brought it up to him. And that's really what made him aware that, you know, I may not just be your standard patient coming in, but also brought the point that, any patient going in is going to get a blood clot, or have the possibility of developing a blood clot as a result of this type of surgery. But that information is not being passed out. The biggest disparity is the reluctance to see by the orthopedic community to use anticoagulation prophylaxis. Their concern appears to be more about the bleeding issues than it is of the clotting issues. And yet, DVTs, as a result of knee and hip replacement surgery, is one of the leading causes of hospital-acquired blood clots. And knowing I was going to the surgery as a high-risk patient, at no time did the orthopedic surgeon recommend anticoagulation management until I had brought it up. When I asked him whether or not there would be someone assigned to the surgical unit that would be monitoring my anticoagulation management, his answer was no. I arranged through the staff hematologist to have someone come in and monitor both my pre- and post-operative anticoagulation. Following surgery, I was lucky to be in a room with a person who had the same surgery done earlier that day by the same surgeon, and that was good because I got to balance off symptoms that we both were experiencing to make sure that what we were experiencing was not out of the norm for that procedure. The big disparity I saw was I was being monitored while on anticoagulants, and the other patient was not. He was only on aspirin therapy. Talking to several other patients on the floor, they also were only on aspirin. The orthopedic community as a whole needs to instill into their surgeons that the risk of developing blood clots exceeds the risk of patient bleeding. Public awareness and patient awareness doesn't stop at that level. It needs to also take place within the healthcare community.